Welcome to this week's edition of Freedom and Prosperity Radio, the weekly radio news magazine put together by all of us here at the Virginia Institute for Public Policy. My name is Joe Thomas, and you can find out more about us at the website virginiainstitute.org, and our archives of previous episodes of this program are on our YouTube channel. Search Freedom and Prosperity Radio. Our first guest has dug into the numbers on so many different things, and we turn to him when you really want to get the truth out of the numbers, which sadly, I was always told that numbers are supposed to be incapable of lying to us, and then I learned about statistics. Shane Chalke is on with us, actuary, mathematician. Of course, find out more about him at the website howmuchrisk.com. Happy New Year, Shane, and welcome back to the program. How are you doing?
I'm doing great, Joe. Nice to be with you today.
So you have dug into what, even to somebody with rudimentary mathematical skills like me, just screams that nothing in the COVID-19 pitch adds up, pencils out, whatever you want to say. When was your first inclination that there was some mathematical chicanery going on?
Well, I think I started looking at this way back in March, and it's interesting that I did this not to publish, but just to find out for myself what the heck was going on, because the one constant in this entire pandemic is that whatever the press reports is probably worse than it actually is. And that's not true just about this. That's true about weather. It's true about everything, right? So I just wanted to know what a little bit of reality was. So I started modeling, building my own models and trying to project active cases as time goes on. And I was constantly fighting corrupt data. I shouldn't say necessarily corrupt, but data that was squirrely. Because what would happen is once we got into the pandemic, various state health departments would comb historical records and come up with new cases and then report them in a lump, and it looked to the press like there was some massive growth. Maybe there wasn't. Some of these cases were 3 weeks old or a month old or 2 months old. So I spend a lot of time trying to clean that up and try to figure out what's really going on. Is this disease growing or in decline, and where is it growing and where is it in decline?
Well, it's interesting. You'd think that our health department would be interested in doing the same kind of actuarial mathematics.
You'd think so. Most of the information that people get is from the private sites that aggregate state data, because the federal government has done a fairly poor job at this. So people look to Johns Hopkins' website. They look to the COVID Tracking Project, Infection 2020, and so forth. And these are the sites that pick up information from the various state insurance departments. And some of them do it better than others. It is a monumental task, because if I simply go to all the 56 or 57 jurisdictions in the United States and pick up the current caseload or the current reported cases each day, that's not very useful to me. I need to clean that up, because the sands are constantly shifting. I'll see states that will, maybe be reporting 1,500 cases a day, and then there'll be a day where there's 9,000 new cases. And I go, okay, something's up here. That's not right. And you look into it and you find out that these are perhaps historical cases from a retroactive study that get reported. It's not necessarily the state's fault. They're doing these studies and they report them. Some states do a fairly good job at reporting them back on the dates that they originated from, but the aggregation sites generally don't pick that up. They're just looking at total cases day to day and reporting it as it is.
I've said that, we don't have a lot of experience in broadcasting news and information during pandemic. So, the gaps in between leave, people grappling with how to do it. And I've reminded people that, when we hear from a doctor at Johns Hopkins or at UVA Medical Center or wherever it is, this is just where they are right now. And that there's nothing wrong, although it seems like they're very want to go back and say, okay, we found out something that we didn't know a month ago that we just figured out, and so what we told you then is different now. Has that harmed our response to COVID-19, that when information has changed, rather than saying, hey, you know what we thought we knew then is different, we get this sort of circle the wagons and say, no, what we said to you then was right, and what we're saying to you now is right, and that's ruining the American trust in what our healthcare departments are saying?
Yes, I think that's true. I mean, almost everyone gets sort of stuck in their way of thinking, and if you find something to jar you out of that mode of thought, you resist it. So I think the big things that happened in this pandemic were fairly early on. I was able to calculate mortality rates for this disease. I think I did my first mortality study in late April, which is quite early on, and concluded that the overall mortality rate was about 0.5%. It's since declined since then, but that was during a time when most news outlets were reporting 5 or 6% case fatality rate, which is a misleading statistic.
Let me poke into that just for an example for our listeners. So how did they come with the misleading statistic? What were they culling it from, and how did they come to it poorly to make it seem so much different than yours? Just for an example for the listener.
Yeah. So very very simply, what the media did, and most people reporting on this, they simply took the number of reported cases and looked at that in contrast to the number of reported deaths, and early on, that's called the case fatality rate: known cases, known deaths, and that was running 5 to 6%. And the problem with that is we discovered not too long after that, I'd say by May, that the number of reported cases was a fraction of the actual cases. So it depends which study you looked at during the, let's say, May through July time period, but actual cases were anywhere from 10 times to 50 times the reported cases. So obviously, if you're missing, let's say, 80% of the cases, you're going to get the death rate wrong.
Right, and a lot of that is attributed to things like asymptomatic, possession of the disease, and so somebody might turn up positive, having never felt sick, so they never had gone in to be tested, and then they come back with antibodies. Oh, you had it, and then they go into a statistical pile.
That's exactly right. I mean, there's many reasons why we only captured a fraction of the cases back then. Part of it was testing was more limited than it is now. Now it's ubiquitous. Part of it is if you have mild or no symptoms, you don't bother to get a test. I mean, and the third reason was the testing protocol was fairly strict. As just a citizen, if I was worried I might have been exposed, I couldn't just go get a test. I had to meet certain national protocol in order to qualify for a test. So we're capturing a small fraction, and as a result of that, we were, one, overstating the mortality rate. And the second big problem with that lack of recognition that we were capturing such a small percentage was that we stuck with this idea of contact tracing for so long. Contact tracing works fairly well with very limited numbers, but if a disease is spreading ubiquitously and silently, that you don't know about it, contact tracing is almost worthless. And so we stuck to that for a long time. I don't think people put much credence in contact tracing today.
Shane Chalke is actuary, mathematician, and we're kind of going through his analysis of the COVID-19 numbers. Now, I appreciate you indulging our tangent just so that we understand where your context is coming from. So you're saying now, based on all the numbers you've been able to cull in all these different places, mortality rate is hovering around, you said, 0.5%. How does that compare to other illnesses?
Well, it's certainly more, the mortality rate is higher than flu, although interestingly, the COVID mortality rate varies so significantly by health status and age that there are certain cohorts where flu has a higher mortality rate than COVID does. In very, very young people, for example, flu has a higher mortality rate. For the elderly, COVID is worse. I calculated way back in April that for people under 60, the mortality rate is 0.9%. That's very, very low, and that's down in flu-like territory.
Mm-hmm.
But for people over 60, the mortality rate was about 2% or more, and that's still a fairly hefty mortality rate. But it is confined to people who are elderly or infirm, and that fact wasn't well publicized early on and didn't really inform public policy very well. So the idea that we're going to just place restrictions on society in order to arrest this disease were ill-founded, because that might have worked if the disease was the smaller numbers as the reported cases might lead you to believe. But since it's spreading asymptomatically and silently, that didn't really work. And rather, public policy would have been much better to protect those that were vulnerable with expected high mortality rates and let everyone else go about their business, I think.
We've seen this in some of the European countries did that, and they said, okay, well, this is what it looks like if you're in this age or you have these health risks, we need you to do this. The governor a couple of weeks back said that the Virginia population had a 98% complicency rate with his restrictions, yet the case numbers, the positivity rate had chalked up. I think we're at over 11%. Now, number one, I want to get into the numbers and why we're using positivity rate versus other things, other numbers. But also, if we had a 98% compliance with his shutdown orders and we were still seeing the numbers go up, shouldn't we say maybe the shutdowns and the lockdowns and the closing the businesses weren't statistically necessary?
Yeah, I think that's exactly right. I've looked at this several different ways, and there's been many other studies as well. There's a paucity of evidence that lockdowns have any effect. Now, that's not to say that staying at home has no effect. I'm differentiating voluntary behavior from government mandates.
Right.
So, there's some evidence that the government mandates aren't effective because people don't follow them. And there's also evidence that where there's no government mandate, people are still careful. I mean, people aren't dopes. They know what to do. And I've tracked for the longest time North Carolina versus Virginia, which are similar states culturally, similar populations. Virginia's in the 7 million range, North Carolina's in the 10 million range. And these two states, irrespective of their the fact that their government mandates were not at all aligned. There were times when North Carolina was completely open and unrestricted, and Virginia was quite locked down, and times when they're both locked down together. And I've seen no difference. These states have paralleled each other in COVID experience, and it seems to make very little difference what the quote unquote rules are.
So what about positivity rate and things like that? I remember when they wouldn't report that and they would just report the total numbers, and we would try to push the positivity rate in to the discussion. Now the Virginia Department of Health is doing that. Is that a fair statistic, or is that skewed with people who may not have had symptoms but now are being added to the positive case load?
Yeah, well, there are many reasons why I don't even look at the positivity rate. I don't think it's a very useful statistic. Now, let's make clear that if you did random testing in society, if you went out into a county in Virginia and tested 100 or 500 people randomly, the positivity rate would be a very significant number, because we're starting to uncover what the latent or the unknown COVID exists in society. But the positivity rate of people who are either getting mandatory testing because they're healthcare workers or frontline workers, or they are self-selecting, getting tests because they're either thought they had exposure or just nervous about COVID, or are going to go visit grandma next week and want to get a test in advance of that.
Sure.
The positivity rate doesn't have much meaning. It's unless you do random testing, I don't think positivity rate can be interpreted to have much to say about what we ought to do.
Well, what about the whole flatten the curve narrative that was the early part of COVID-19? It seemed like much of what we were doing was to try to keep the percentage of us winding up in the hospital, even though then we come to find out later that the majority of the hospital rooms were empty. They just weren't authorized for use in infectious disease cases. So what we wound up with is, again, statistically speaking, high percentage of the infectious disease authorized rooms in use, but not necessarily the whole hospital there. Talk about how numbers were used to make it seem like hospitals were in a more dire strait. And then we started finding out that Inova and UVA Health were doing furloughs because they were really having a tough time keeping all their employees on.
Yeah, I mean, this is one of the big unwritten stories here is that hospitals had a very, very tough time during COVID. Many of them have been under quite a lot of financial stress, and we've seen a lot of layoffs amongst hospital staff. And part of that is the drive early on in the disease to keep hospital beds open and delaying all kinds of elective surgeries or non-time sensitive medical treatments. So we ended up with a lot of empty hospitals. And hospitals, people don't think of them as a business, but they're like hotels. They need a certain occupancy rate to be financially healthy.
Yeah, the equipment isn't cheap.
That's exactly right. And it sits idle, and you can't pay your people. And so we, I think, made some public policy blunders early on with the idea that we could slow down the transmission of this disease. In fact, I don't know that we ever successfully did. We've had now COVID happen in 3 different waves. We've had the first wave, which was predominantly the Northeast. I mean, all eyes were on New York and New Jersey, and that was in April. And then they reached a certain saturation in society and started to recede very rapidly. And then this is one of the mistakes I made. I said, this is over now, without thinking that, everywhere was going to get it. I mean, this disease is more ubiquitous than we thought. That's the 2 lessons. It's more widespread than we thought, and it's a lot less dangerous than we thought early on. Now, I'm not downplaying its danger. I'm saying it's less dangerous than was initially thought.
Well, I've talked to even the state epidemiologist, and they've said that the more easily transmitted a coronavirus is, any coronavirus, the less deadly it is. And it seems to track in inverse. The harder it is to get a coronavirus, the more deadly it can be. And I guess, running the scale from a common cold all the way up to HIV, all in the spectrum of coronavirus. Shane Chalke is an actuary and a mathematician. I want to go back to something you said earlier. You brought up the I word, insurance. What role does the insurance industry play in our public policy? Because Obamacare had so many more people signing up for health insurance, and there are reasonably high costs in some of the experimental treatments and treatments that you need for COVID-19. Is some of our public policy being driven by insurance companies that are, calling on our elected officials to help keep them from getting crushed under, large numbers of their policyholders showing up in the hospital needing extensive care and or exposing enormous risks with high copays?
Well, actually, ironically, it's worked opposite of that. Because of the medical profession delaying elective medical procedures and non-time sensitive medical treatments, and the deferment of a lot of testing and such, health insurance companies have done better during COVID than than they would in normal times. Now, you did read quite a bit about that over the spring and early summer. You haven't heard much about that lately, so I don't know if that continues to be the case. But that was certainly true early on, is that the aggregate level of medical care went down in this country during COVID.
Is there a mathematical picture to be painted that the public policy makers, decision makers should be looking at to come up with a good plan for this? I still hear very little about treatment. Everything is about vaccine, and I still worry about people thinking they have been vaccinated against something that they are asymptomatic with, and then the spread could even go up after the vaccine starts to get administered. Are there mathematical ways that our public policy makers should be working on, fighting COVID-19?
Yes, I think the first thing that I would cry out for, if this ever happens to society again in my lifetime, is that we need better data. I mean, I don't know where the CDC was through this, but I would think a very important job that would be on their plate was to standardize the reporting of COVID across the various states. So we have different protocols in every geographical area, and even worse, shifting protocols over time. So if I look at a particular state like Washington State, for instance, it takes a lot of work for me to even figure out what's going on because they might have changed their protocol. Mm-hmm. We used to only report RNA positive test cases. Now we report positive cases. Now we report antibody cases. Now we go back in history and we find probable cases. It just goes on. And we're really crying out for some consistent data. So first, we can just measure. I mean, you don't know what to do policy-wise unless you can measure what the state of the problem is. The second thing is, we clung to this idea for so long that this was, quote unquote, everyone's disease. And society kind of figured it out. I mean, at first we faulted young people for socializing and not taking care, but they're smart. They figured out this is not our disease. This, for most young people, and I'm going to get hate mail for this, but for most young people, it's like getting a cold, and that's just statistical fact. And so they behave accordingly. But the public policy didn't behave that way, didn't recognize that this is not a young person's disease. This is old and infirm disease. And so the public policy didn't follow that knowledge and act appropriately. I think we could have saved a lot of lives by recognition of that earlier.
Last one, and of course, this is the one that's going to get me hate mail as well, Shane. My mother is a statistic. She died, and she is listed as a COVID-19 death. When the doctors were very clear with my sister and I that her congestive heart failure was what did her in, but it was accelerated by COVID-19. Other countries list, separately deaths by COVID-19 versus deaths with COVID-19. Is that whistling past the graveyard, or is there something mathematical to be gained, especially as it colors public policy, to look at, how we're listing these? And, of course, you've got the famous stories of, Medicaid reimbursements to hospitals, which have been proven out to be higher for, patients with COVID-19, and maybe that's why they lumped everyone together. I don't know. But, is there a real efficacy to saying, okay, they died with COVID-19 or had COVID-19 before they passed, or they were actually killed by COVID-19?
Yeah, I mean, it's maddeningly, it varies state by state. There are states that report separately the COVID-19 as a complicating factor versus the cause of death, and there are states that lump them together. And then there are other states that have gone back in time and combed through death records, and anything that looked like it could have been COVID gets reclassified as a COVID death. And there's many reasons why this is done, ranging from public officials are just trying to uncover as much data they can and do the right thing, to the fact that it's not polite to say it, but when there's trillions of dollars in federal aid being floated around, there is some incentive to show that your COVID experience is relatively worse than someone else's, because you're going to be in line for more of that federal money. And we've already spent trillions. There's trillions more to come, it looks like. And that always clouds the data. There's just no way around that.
Shane, we got to finish up here, but really want to know what you're working at. What are you looking at mathematically in the future with this? Are there new things you want to continue to work the actuarial tables on regarding COVID going forward?
Yeah, I think the biggest thing I'm looking at right now is a fascination with what happens when the vaccines begin to take effect. I have a working theory that we only need something like 80 million vaccines to arrest this disease and so put it into fairly rapid remission. And so that comes from the fact that I do believe, based on my math, that something close to half the population has some kind of level of innate immunity to the disease to start with. So what you hear a lot of experts say that we need 70 to 75% of the population to be vaccinated before we arrest this disease. I think it's much, much sooner than that. And I certainly expect to see, by the end of February, very strong evidence that the disease is moving into remission.
Well, Shane, thank you so much for being our mathematical Dr. Fauci this morning. I appreciate it. Well, we got to work on a new analogy for him. But I do appreciate everything you've done. Again, you can read it all at howmuchrisk.com, and there's COVID archives there. Shane, you have a great weekend, and thanks for joining us.
Thank you so much, Joe. Take care.
Coming up next, on the legal side of COVID-19, the shutdowns, and specifically the shutdowns in the court system, Matthew Harden, former Commonwealth's attorney, will be joining us on Freedom and Prosperity Radio.